Hi, good afternoon from sunny Zurich. I realise that some of you, looking at the number of participants, are from across the world, so good morning, good afternoon or good evening, depending on where you are. Delighted to welcome you to this webinar, which we're running today on the basic science of fracture management. I'm Mark Jackson. I'm an orthopaedic and limb reconstruction surgeon from Bristol in the United Kingdom, and I'm pleased to be joined by one of my colleagues who's from Oxford, Bob Handley.
Hello, my name is Bob Handley. I'm a trauma and orthopaedic surgeon. I'm based in Oxford in the UK. My role this afternoon is to be the chat moderator, which means that my typing skills are going to be taxed to their maximum when your questions come in. We'll answer some questions on the way through, but others which are going to need a more in-depth discussion I'll save until the end of the initial presentation, when we have 15 minutes set aside for discussion. In the middle of this, the presentation, there are two embedded questions for participation, and we'd like your answers to those as promptly as you can, and because we'll use those to furnish the discussions at a later stage. So I'll hand you back over to Mark for the presentation.
Okay, thanks, Bob. We're going to be going through this, the basic science of fracture management. I'll just lay out my disclosures first of all and move on to the learning objectives. So I'll be introducing a number of concepts to you, one of which is the bone healing organ or unit and how that's involved centrally in fracture repair. We'll also look at the biomechanical and biological factors in healing fractures. We'll introduce the concept of the unified theory of fracture healing and explain how we can use that to mechanically manipulate the bone forming organ. So we're going to review the principles of bone healing and fixation. What I'd like to do is we'll just give you one of the embedded cases that just gives some food for thought to start off with and get your feedback, and then towards the end we'll discuss this in more detail. So this is a 34-year-old man. He's quite overweight, 150 kilos. He sustained a closed right femoral shaft fracture. This undergoes retrograde intramedullary nailing, but with an open reduction. And despite adequate fixation, at 6 months, he's still in pain and is unable to weight bear on this. So I'll just show you his radiographs initially. So a standard isolated mid-shaft diaphyseal fracture. And this has been treated by reduction and fixation with relative stability using a retrograde intramedullary nail. This is the radiographs at 6 months. As I said, he's unable to weight bear, and we're going to give you a range of possibilities that might be used to manage him. So at this stage, this is 6 months. Would you observe him? Would you use autologous bone grafting? Would you insert interfragmentary screws, or undertake exchange nailing, or perhaps compression nailing at this stage? I'll just give you a minute to think about that and to continue. So I can see the figures coming in. We've broadcast them, so they should be on your screen now. So quite a few people, probably the majority, would continue to observe. Some would undertake exchange nailing. Hardly anybody would do interfragmentary screws. Few people with bone graft, and just a few people with compression plating. So as I said, we'll continue with the presentation, and then we'll look at this in a little bit more detail towards the end. So the overview of this talk, we're going to look at the principles of bone repair, how we can manipulate fracture repair, the influence of stabilization on the process and the properties of various implants, and importantly, how do you change this if the process hasn't proceeded smoothly and it's gone wrong. So let's talk a little bit about what happens. So fracture union, the process, depends on two main factors, which are biological and mechanical. So the biomechanical stability, but also the biological vitality of the tissue. And it will heal by the formation of bone, and then to bridge and cause union, the bone needs to bridge across the two ends of the fracture. And this can happen without treatment. And we'll see this case again then. This is a dog model with a comminuted femoral fracture, which has been treated without immobilization. And what has happened is slowly it's gone on with disorderly callus formation of woven bone. And despite the fact there's significant deformity and malalignment, the fracture is soundly united. And the key point from this is that the mechanical properties and the biological properties of this fracture will evolve during the process of fracture union, even if it's not treated. So just looking at breaking down fracture repair into just the simple steps is clearly a fracture occurs, and that provides a stimulus, a signal to start the process of fracture repair, which then involves bringing forward the appropriate materials, the vascularity and tissues for healing, and ultimately, hopefully, progression of time, this will lead to fracture healing and union for the patient. Well, how does the bone form? In one of two ways, essentially with a cartilage precursor or with endochondral ossification, or by a process of bone formation from bone precursors, osteoblasts, in an intramembranous ossification process. And involved with this, there are key elements, including the inflammatory response, the response of new blood vessel formation, angiogenesis, and the formation of bone, osteogenesis. And all these three are involved at various stages, synchronously and metachronously during the process. So bone formation, we're familiar with endochondral ossification and the formation, as in a child's growth plate, of bone and longitudinal growth via chondroblasts, i.e. a cartilage precursor. Or we can have direct appositional bone formation onto the surface of bone by osteoblasts in a process of intramembranous bone formation. And what we can see is that stability of the fracture determines which one of those methods of bone formation is predominant. So absolute stability will tend towards intramembranous bone formation. Relative stability will have a cartilage precursor stage. So the initiation of this process is by an injury, and the injury will cause an inflammatory response, which is key to the initiation, but the start of the process. So that the inflammatory process will be mediated and will also activate specific bone cytokines to lead to this orderly sequence of repair that we see. And bone activation, on the left-hand side, we can see a slide of a bone section, a normal bit, which is not activated, but by the process of either fracture or surgical corticotomy or by application of transforming growth factors, we see activation, and we can see on the slide on the right side that there has been proliferation and intensification of the function of osteoblast forming bone by that process. So what is the influence of stability upon this process? Well, it's fundamental in our treatment of fractures and how we can influence it. So what we know, as bone is loaded under physiological conditions, it will bend, it will deform. Normally that's relatively small amounts, and in absolute terms it's probably about 600 microstrain, so a very small amount. At a amount of approximately 25,000 microstrain, or about 2 to 2.5%, it will fracture. Once it's fractured, clearly without stabilisation, there is movement, interfragmentary motion between the bone ends. And this can be influenced principally by the technique and the way in which we stabilise fracture during treatment. How does this work? Well, it's not precisely known, but it's thought that mechanical stability will act by a number of mechanisms, but particularly in affecting local vascularization and angiogenesis. And by that means it will affect tissue differentiation. And that's possibly modulated by hydrostatic pressure. And we'll see some work that looks to suggesting and confirming that as a mechanism in a second. But one of the key things is that the mechanical environment changes, and what is needed by the fracture evolves during the process of fracture repair. And we'll look at that when we come to the unified theory of fracture healing. But we need to get changes during this process to get a smooth, orderly process towards bone union. So a little bit of movement is good. In fact, it's absolutely essential. So these two radiographs are of an experimental model which has been stabilized using an external fixator. So there has been a cuneiform defect created which has been stabilized, and in one arm of the experiment has been subjected to a little bit of micromotion, just 10 cycles per day over a period of 5 weeks. And on the right hand side, the experimental model has not been subjected to any micromotion. And we see that with the added micromotion, there is early, fairly abundant periosteal callus formation. Where there has been a gap and absolute stability, there has been absolutely no callus formation at all. So micromotion is important in allowing the process of fracture repair to progress. And this is a key publication by John Kenwright, who did quite a number of experiments and work in the 1980s and 1990s, looking at the influence of motion and fracture repair, principally with external fixators. But this is an experiment where they treated tibial fractures in clinical practice with added micromotion. And what they looked at was that they found that it was necessary to maintain stability throughout the process. And indeed, if you had a lack of stability, particularly during or after the initial phases, that this amount of motion caused abnormally high stresses and strain and damaged the repair tissue in the fracture gap. So the take-home message really is that you need to control the fracture mechanics throughout the healing process and change the stresses and strains during that process to get assured union until you can remove the external fixator. And we can see just in one example, this is a case of mine from some time ago, where I treated an open children's fracture with absolute stability. And you can see in the zone, in the tibial fracture treated with compression plating and interfragmentary lag screwing, that we've got primary bone union and absolutely no callus formation. Whereas in the associated fibular fracture, there's been no stabilization surgically, and we have relative stability, and this is healed by the formation of external callus. So it provides, even in the one fracture, the one limb, a spectrum of stability, which has given us different patterns of fracture healing. We can see that that's looking at the whole limb, but looking specifically, this is a diagram of or a schematic of a healing fracture, and you can see that the area adjacent to the fracture there is where there is endochondral bone. So this is an endochondral ossification area. This is bone formed by direct appositional processes by osteoblasts. And you can see that this area where there's endochondral formation is adjacent to the fracture where the interfragmentary motion is the greatest. At this point where there's intramembranous bone formation, it's at its least, and there is a gradation of interfragmentary motion between those two areas. And we'll look at this a little bit more closely in a second. But essentially the gradation of stability has given us different tissue in the gap. Lutz Claes is professor of orthopedic surgery in Ulm in Germany, has produced a number of publications looking at this, and I'd just like to concentrate on this one publication for a second, which looks closely at the influences and why this might happen even within the same fracture. And what he used was a sheet model looking at metatarsal fractures. And what we have on this side here is the diagram of the way in which bone forms. So initially bone forms here, and during fracturing it progresses until you have final bridging. And this is the last part of the process. But allied to that, we also have the formation of intramedullary callus intramedullary bone. And you can see that's the diagrammatic version. On this side, the two clinical histology slides, which show that the dark area is the stained area corresponding to fibro cartilage, which persists even after there has been bridging bone. And it's in that zone immediately adjacent to the fracture area. And what he then went on to do is to do a finite element analysis, having looked at the animal model, and use this to look at hydrostatic pressure within. So as the bone is loaded, that will produce transfer of fluid around that. And he's mathematically modelled this. So what we can see on this graph, and I'll take a little bit of time just to explain it, is strain on the y-axis, positive strain there, negative strain there, and then hydrostatic pressure plotted along the x-axis between compressive and tensile. And what he found is that high strains above 15% and at high compressive and tensile loads, the tissue formed, or that was tolerated by that, was connective tissue or fibrocartilage. And as we get the progression of healing, or perhaps the arrest in the case of a non-union, we find that the strains and the hydrostatic pressures change. And when we have compressive hydrostatic pressures, which are of a magnitude of less than plus or minus 15% strain, we then have endochondral ossification. And when we have very low strain, less than 5%, and either tensile or compressive hydrostatic forces, we'll have bone forming by intramembranous ossification under those circumstances. So it brings us really and twins up with Perrin's strain theory that the tissue within the fracture gap can only exist if it does not exceed its limits of elongation. And to reduce the forces on the tissue, there's a number of mechanisms that the bone will use. So one of them is fragment end resorption. It allows the formation of appropriate tissue and progresses to external callus formation. If we have a model of a fracture, which we can see here, with a narrow gap, this is tissue in there, and if that's deformed by bending, we can see that this generates large strains on this tissue, which is likely to be beyond the limit that that tissue can exist at. And if you look at x-rays 2 weeks after even anatomic reduction with a nail, you'll see that there's a little bit of bone resorption, and you see a fracture gap that wasn't there on the initial radiographs. And that enables the tissue in there to reduce the strain by the fact that the gap is now greater, the deformity and the interfragmentary strain is reduced by that resorption, allowing that tissue to be able to withstand that load even under deformity. And it gives us a sequence of really stiffness and tissue of what it will tolerate, from hematoma through connective tissue to mineralized bone. And the Young's modulus of that tissue will change during the process. So we go from granulation tissue, which permits large angulations because it has a very low Young's modulus, to stiff tissue, as in bone, with a relatively high Young's modulus, which will only tolerate relatively small degrees of angulation. And we can see that this tissue will coexist in one fracture. So this is a diagrammatic representation of the tissue in this fracture gap. And looking at this, we can see that there's areas of cortical bone, granulation tissue, and woven bone. And the Young's modulus will change. So all these tissues coexist within a single healing bone-forming unit. And the effect of external fracture callus is also quite clever. So we remember from our biomechanics that the stiffness of a tube or a solid object is proportional to the fourth power of the radius of the bone in this case. So what that implies is that only small increases in the diameter will significantly increase the stiffness. So if we go back to our diagrammatic representation of our model, if we take a diameter across the normal bone here, and we put that into our equation, we come up with a stiffness at an I of 0.7. If we then do the same across the callus, area of external callus, which is about twice the diameter, we see that when we put those into the equation, because it's the fourth power of the radius, that the stiffness is an order of magnitude greater, and that's predominantly just by the increase in external diameter of the external callus. What about the implants that we use? How can they influence the way in which the mechanical environment of the fracture may change? This is a tibial fracture. We could treat it in a number of ways. We could treat it with intramedullary nailing, compression plating, monolateral or circular frames, or percutaneous bridge plating. How does that alter the stability? Well, let's put these onto a graph where we've got basically absolute stability at this end, going through a spectrum towards relative stability and instability at this end. So what we would do is put our compression plating with interfragmentary lag fixation, primary bone healing, absolute stability, and we would put our intramedullary nailing in the relative stability section, and we can see that we've got external callus, but it's also symmetrically orientated around the axis. Interestingly, we've got relative stability with a monolateral fixator. But what we see in this instance is very asymmetrical callus, so nice callus formation on the side away from the fixator, but relative suppression of that on the side next to the fixator. We have bridge plating, which when used with locked screws provides us with a very stiff construct, and this is probably at the primary bone healing, the absolute stability end of the spectrum. And with circular frames, it's very stiff in terms of restricting shear, but allows lots of axial micromotion, which is thought to be really quite osteogenic. So let's apply this to problems. So these are not fractures which are obviously contaminated with gross infection or ones with significant bone loss. So these are fractures that are nailed and you think should heal or treated by plating. And this really brings us on to the unified theory of fracture healing. And some of you may have read this. This appeared in the Journal of Bone and Joint Surgery about 2 years ago, and was produced as a kind of consensus document by a number of orthopedic surgeons who are experienced in the management of fractures and also in the management of fractures that are not uniting. And this really puts forward the concept of the bone forming unit and how that's been affected by its mechanical environment. And it brings elements from Perrin's strain theory, from Wolff's law in terms of bone homeostasis, and also gives us glimpses into Powell's thinking in terms of bone formation and strain environment, as well as the work from Lutz Claes. And again, just to look at this and emphasize the differences between stress and strain. So stress is the force, and this gives units of force per unit area, and that's the deforming force. The strain is the amount of deformity that defined stress will cause. So it has no units, it's the change in length over the original length, which gives us a percentage. So in these examples, we have a small fracture gap, but interfragmentary motion, and that produces very high strain, and that may cause damage or will cause damage to the tissue in that fracture gap. In the lower example, we have a much larger gap, and although the deforming stress is the same, the strain that this produced is much reduced by the fact that the overall size of the fracture gap is much greater, producing much lower bone strains. So the key point of this paper is looking at the way in which fractures evolve and the physiological and pathological ranges that we see. So that we can plot out, this is net bone formation, net bone resorption. And under very high bone strains, interfragmentary strains, we get bone resorption. So that may occur in a non-union. But in this range, we get net bone formation. And what is happening is hopefully our fracture is going from the right-hand side of the graph to the left, and we'll see that in a minute. Homeostatically, in the normal situation, we're looking at the situation from A to B. And if we look at our original fracture model with no stability, and at this point, immediately post fracture, we have very high bone strains, way beyond point C. And as that heals, it evolves into much lower strain until the fracture unites, when we're then back into the normal range at this point. And if we take out this part of the graph, so this big graph is this section between A and B. And this is the section that bone operates under normal physiological conditions. So this is within the strain bone window here, where Wolff's law is applying. At this end, where we have bone resorption and very low bone strains, it's maybe associated with prolonged bed rest, or very excitingly with astronauts in zero gravity positions where they will lose bone mineral. But at this end, where we have high bone stress, we may get a healing or a stress response depending on how that has occurred. And we can take that forward to look at how this might influence our clinical practice. So this is taking out that part of the curve, and this is our progression from high interfragmentary strains immediately post-fracture to lower strains as we're going towards fracture union. And that may be influenced. We may get a slower than normal bone formation for whatever reason, but sometimes this may be because our strain window is actually much narrower than normal, and patients with what would be reasonably normal in some patients may not be able to, for whatever reason, form bone. And then in some patients, they may have an inability at that level of interfragmentary motion to form bone at all. But what we need to do, if we see that our normal progression is from right to left on this curve, and hopefully most fractures will progress to union without problems, but if they're arrested and we have a situation of either delayed or non-union, what we need to do is to shift this curve towards the left-hand end to encourage union by mechanical means. And it's recognised that non-unions will have a biological cause in some cases, but the overwhelming majority in clinical practice are due to mechanical problems. How can we achieve this shift of the curve? Well, we could reduce the external load force, we could immobilise the patient, maybe put them into cast, or we could act and operate to reduce our interfragmentary strain. And that may include also correction of axis, which will provide very asymmetric loading and asymmetric forces on that callus. So we're now back to our case. So this is the one that we polled you initially. So this is the 34-year-old guy, very large, closed fracture, and has gone on to not unite at this stage. And this is where we left him with pain, a little bit of callus formation. So the suggestions we had were either to go ahead and do autograft, to exchange nail, to observe, or to undertake some other procedure in formation of interfragmentary restriction of motion. So what we've opted to do is a very minimally invasive procedure at this stage, which we've done as a day case. And what we've done is simply acted to shift our curve towards the left-hand side. And what we've done is put in interfragmentary screws, and we've also, to reduce shear, because it's a relatively small nail, is put in blocking screws to reduce that motion as well. So this is the situation at 6 weeks post-operatively. We're also starting to get a little bit of abolition of, well, patients more comfortable with starting to get a formation of callus with this screw setup. At 6 weeks, we've got definite progress, and by 5 months post-operatively, with a simple intervention of interfragmentary screws, day case surgery, we've got union, and he's able to comfortably weight bear. So we've not used bone graft, we've not undertaken any significantly invasive procedures, this day case surgery. Sometimes life is a little bit more complicated, and this is the second case. This is a 26-year-old man who had a grade 2 open fracture. It was treated by lateral percutaneous plating. But unfortunately, the plate broke, and we got implant failure, and he's developed a varus malunion. So one of the warning signs at this stage is he had an open fracture, hasn't united. So one of the worries that this may be complicated by infection. So we'd like to ask you another question briefly to get your views on this. So this guy's got implant failure, hasn't united, so we're going to operate. The question is whether you would, at the time of surgery, take samples for microbiology. Would you take samples for microbiology and histology? And coupled to that, would you give just prophylactic antibiotics at the time of surgery, or would you give those and then continue the antibiotics, broad spectrum antibiotics, until the definitive cultural results were available, which is probably going to be about 7 to 10 days if those are going to be a definite negative. I'll just give you a minute to poll here. So people are keen on sampling for both microbiology and histology, so that's good. And people are tending maybe to give prophylactic antibiotics and then continue. So that's the final result there. So it's quite nicely spread across there. Okay, well, we'll see what we did. So I think surgery is definitely indicated at this stage. So we need to shift the curve or shift our graph and reduce the interfragmentary strain. So there's a number of complicating factors, the broken plate and the deformity and the possibility of infection. So this is not a case where we could do a minimally invasive procedure. We need to correct the axis. And this is one where we've applied a circular frame. And what we've done here is actually distracted very rapidly. This is a stiff non-union. So I've distracted that by approximately 15 millimeters over a period of 2 weeks. And during that time have corrected the longitudinal axis. So we biopsied this chap at the time when we took the plate out, excised a little bit of his fibula. The biopsies surprisingly were negative in this case. I would have expected them to be positive, but in fact they were negative. And once we distracted this, we then gently compressed this And then this is the x-rays following the frame removal, and this is within 6 months. So the frame was on for a period of 16 weeks, achieved union, and this is remodeled union at this stage without symptoms. So we've stiffened it, we've corrected the axis, and we've provided symmetry of loading. So the deformity will, of course, very asymmetric loading between the two sides. So to summarise what we've talked about, I'd like to highlight the importance of vascularity and skilled and delicate surgery and preservation of soft tissues around the fracture. Hopefully you now have an understanding of some of the mechanical aspects of fixation and have been introduced to the unified theory of fracture repair and the ability to modulate and to change the mechanical environment of the fracture to encourage union, and have been able to unite these fractures without the use of autologous bone graft. So at this stage I'd like to throw open the discussion. I'll hand you over to Bob Handley, and we can take your live questions and discuss these before the sum up at the end. So over to you, Bob.
Thanks very much, Mark. Thank you very much, Mark. I've answered a number of the questions that we've gone through in text, and those that we haven't addressed, there'll be 15 minutes after the end of the formal webinar when we can answer some more questions in text. But there are some other areas that bear further discussion that have come out as questions. One of the questions was, at what stage would you regard a pseudarthrosis as having developed? When would you consider that to be the case, Mark?
Well, I think in my practice that they're quite unusual. There are certain groups of patients where they're, I think, more likely, and I do see them. And these are essentially the patients with a neurological problem, either peripheral neuropathy, and that may be alcoholic, nutritional, or most commonly, certainly in the United Kingdom, is a complication of diabetes. Under those circumstances, we do see pseudarthrosis, not usually in the long bones, but occasionally. And I think that is the one indication where surgical resection and exploration of the non-union is necessary. That means to say in the vast majority of cases that we see, resection of bone or opening of the non-union is not necessary to gain union.
And another question that came up was, why was there a need for a unified bone theory? Wasn't Stefan Peren's strain theory adequate? I'll answer that because my name was one of those on the unified bone theory. I think that it came about because the group of us that were involved in publishing that had all been extensively involved in predominantly AO courses, delivering the early lectures in the course talking about bone healing, and felt there was need for some expansion to allow the theory to fit more clearly in with our clinical practice. And so it was an agglomeration of the ideas generated from lectures, primarily by David Elliott in the first place, but then brought together by the rest of us. So I don't think it certainly doesn't rewrite Stefan Peren's theory, and that's the cornerstone of what we talk about. But I think it amplifies it with the importance being put onto the mechanical environment in which the fractures are failing to heal, which is where the questions come up. Another area which is just like to expand upon, the bottom of the last slide that you had, Mark, mentioned about not using autologous bone graft. Yeah. Do you feel that there is now a place for autologous bone graft? I must say my personal view on that at the moment is that I very, very seldom use autologous bone graft just as an adjunct for fracture healing in itself. If there should be a bony defect that one's trying to address, then there may be a reason for it. But just to promote bony healing, I don't use it. I manipulate the mechanical environment. Would you agree with that sentiment?
Yeah, absolutely. I think there is certainly a role for autologous bone grafting in small contain defects, and particularly if you're using or intending to use a masquelade type technique. But I think in terms of stimulating bone union, I don't think there's a significant place for that in practice. And over the last 25 years where I've had an interest in the management of non-union, I've not used that in straightforward cases to get fracture union. I've manipulated them mechanically to do that.
We've had a question from Edwin in Ecuador asking about your weight-bearing practice, or how you advise your patients after a procedure, particularly in bridge plating or relative stability. So I would interpret this to mean, how do you advise your patients in the light of the changing mechanical environment that's required for fracture healing? Do you advise early weight bearing, late weight bearing? How do you go about it? And then I'll expand with my views.
I think that's a very interesting question. I think you can look at clinical practice, and you can also look at evidence from experimental models. I think it's unusual that patients, unless they've got a neuropathy following a fixation, say, of a tibial or femoral fracture with relative stability techniques such as an intramedullary nail, are able to fully weight bear from day one. So there is a degree of pain inhibition, but I wouldn't purposely limit weight bearing in these patients. If they're able to control weight bearing, if they're young and fit, I would restrict, particularly in bridge plating, their amount of weight bearing, but they could weight bear comfortably, and I think safely, up to 20% of their weight from day one. With intramedullary nailing, I'm happy for them to weight bear as tolerated, in the recognition that they're unlikely to be able to fully weight bear due to symptoms of pain. The problems come, I think, in the neuropathic patients, the diabetics, where they have no concept of protected weight bearing because they have no joint position or proprioception. And that's a group where we do see, as I said, the pseudoarthrosis, but also they're commonly complicated by implant failure. So those patients, that group of patients, I think are a real problem. But in normal practice, I will allow patients with relative stability to weight bear as tolerated.
I think one of the phrases which has come into more common use in practice that I've been involved in is suggesting that patients follow their instincts. And it seems to work very well. It works well in children. But there are clearly some instances where patients following their instincts don't help. So those who have got a neuropathy are at one extreme, where they don't have the feedback to be aware of what's going on. But you also get a group of patients whose instincts are clearly wrong by any normal standards. So you find some patients are very keen to get back to high-level activity very early and push themselves in a sort of militaristic approach of no pain, no gain, and they can not help their fracture healing. So under those circumstances, I would counsel people about weight bearing. If I do any interventions later on to try and promote bone union, then to try and reduce the strain environment, you can protect the local area mechanically, but you can also reduce the stress. And so I would combine the two. So in somebody with a slow healing fracture, if I do something to it, I do then suggest that they reduce the loading on it to reduce the strain environment at the fracture point. Another question which has come in from, let me find it. In the femoral case that we discussed, I'll find the name of the person who brought it in a moment. Do you freshen up the fracture ends prior to the stabilization? So in the case that you presented with the intramedullary nail and the augmentation, did you freshen up the fracture ends, Mark?
No. The reason for that is that we're doing this as a day case. We want to be minimally invasive, which is one aspect in terms of just the management of the patient, but also is the preservation of vascularity of the tissues around the bone forming unit. So we want to do as little as possible collateral damage by our surgery, And I think at that point there's no clinical imperative or indication to resect the bone. So we do the minimum possible in terms of soft tissue exposure to allow you to position a drill and to be able to put in an interfragmentary screw.
And I would agree with that. The concept behind that procedure is just to amend the mechanical environment. You're not trying to do anything to the biological situation there at all. And so the less invasive the procedure, the less likely there is to be hematoma around there and any propensity for wound problems. So it's done through a minor stab incisions, just stabilising across the fracture plane, either with or without lag screws. They're not necessarily compressed. Question here about do you consider that when you've operated on a fracture for a non-union, if there is a defect in the bone, how do you fill that defect if you believe it to be structural or just a bone void? What would be your practice in that, Mark?
Well, I think it depends a little bit on where it is. Is it diaphyseal? Is it metaphyseal? And the age of the patient. I mean, in many cases, particularly in children, the defect may just fill without any particular intervention. If I think that it's critical in terms of offloading an implant, then I may fill that with a void. One of the situations that I find myself in sometimes is where I'm referred a patient who's had some bone removed, cuneiform defect at avulsion wedge, and I'm left with very point contact between two bone ends. And I think you're then faced, if it's a significant defect, with a choice. And that may be either using a void filler in a masquelade type technique, or actually going further and doing a bone resection and getting square bone ends and then doing a short bone transport. And I think whichever I do depends a little bit on the clinical circumstances, but often I find that it's actually quicker and easier to do a short bone transport than it is to fill that with graft. So I think the answer depends on the clinical presentation, the age and the type of the patient, and the size and method and technique by which you stabilise that fracture.
My typing and reading skills are being taxed now. We have a lot of questions. It's really good. I like this one from Francisco in Argentina. He asked, how long would you wait to increase the stability in a hypertrophic non-union? I think this is a good question because it's the problem that you're posed in the clinic when you're sat there looking at the patient, and it'll vary with a number of considerations. One is the confidence that you have in the durability of the fixation that the patient has. So if somebody has a modern intramedullary nail which has got and it's a relatively mid-shaft fracture, so it's well fixed distally and proximally, you can rely on that as being sound to take the patient's loading for at least 6 months. And the study, the START study from the States looking at reamed versus non-reamed intramedullary nails in the tibia would suggest that you shouldn't interfere in any way before 6 months with a delayed union of a tibial shaft fracture. However, if you plated a fracture and you're looking at your fixation thinking, this is going to fall to bits if I leave it a lot longer, you may feel that you need to intervene at an earlier stage. And so I would think that if you look at practice, people are intervening earlier with a plate fixation than they would do with a nail fixation because of their perception of the durability of the mechanical construct that you have. Would you agree with that, Mark?
Yeah, I think if you're going to do that, one of the important things, I think if they're symptomatic, unable to weight bear, then I think that's a very reasonable, minimally invasive strategy. I think one of the other things that it's important to obtain is a CT scan, and that gives you evidence and information about the obliquity and the plane of the fracture, and that really guides your surgery. But I think the clinical appearance, if they're still getting symptoms, they've got poor function, then I would intervene sooner rather than later. If the radiograph is the main problem and the patient is functioning well, and as Bob said, they've got a stable, durable implant, then my inclination to intervene would be much less great at the early point.
Gianluca from Italy asks, can simple fracture patterns be fixed with relative stability, and how do the biomechanics change? I think this is a good question. When the locking plates first came available, and there was a tendency for us all to play with the new technology that we had, and as a consequence, locking screws were being used perhaps more frequently than they should have been. Simple fractures were being fixed in a bridge fixation with a bridge technique, and the plain fact is that quite a lot of them healed perfectly satisfactorily. And so there are a number of simple fractures that if they're bridged will heal, but there are some where the mechanical environment doesn't seem to be correct, and you keep that plane of ununited fracture, which then progresses to a delayed union. Interestingly, if you have not a simple fracture, if you have a multifragmentary fracture, and that matures to a delayed or a non-union, that will mature to a single plane, and you'll then end up with effectively united. It's very unusual to have two planes of non-union. So the mechanics resolve to an area where stresses are concentrated, and those concentrated stresses maintain a high strain environment. And so I think, yes, you can fix simple fractures with bridge plating, but it's probably not the ideal technique, but you will get away with it on quite a number of occasions. Would you have anything to add to that, Mark, while I'm looking for the next question?
Yes, I would agree with that. I think probably for mid-shaft diaphyseal fractures, generally speaking, a bridge plate technique is probably not appropriate. And certainly if you can use percutaneous techniques, then I think in the diaphysis, I would definitely not use locking screws in most adult bone unless there's evidence of very significant osteoporosis. So I'd use the locking screws in the metaphysis to get angular, stable fixation, but in the diaphysis, I'd use simple cortical screws.
I think the other way of looking at that is that for the vast majority of my practice life, we fixed mid-shaft femoral fractures with a bridging technique. We've used nailing, and we use it in the full expectation that it's going to heal. And so the argument about direct bone healing and direct compression usually comes up in the context of plating. We've been happy to use it with nailing for many years. Edwin from Ecuador asks, can the healing of bone be improved with the addition of platelet-rich plasma, PRP, at the time of the initial surgery? So I think our whole thrust with the bone healing unit and the unified theory of fracture healing was that these adjuncts are, by and large, not necessary and not helpful. And when people talk about them in the lectures, you'll often hear the terms such as pixie dust, which is a little bit of a derogatory term to suggest that you're perhaps sprinkling something that you hope is going to be a little magic on the environment. And that's said in a way which possibly isn't fair, but I think reflects the attitude that we feel that they're unnecessary additions, and unnecessary additions may have their own complications, and certainly will have their expense. And so the vast majority of delayed or non-unions can be dealt with by manipulating the mechanical environment, and biological adjuncts are by and large not required. Would that fit in with your practice, Mark?
I think that would be entirely my practice. I think that there's very little evidence to suggest that addition of bone morphogens to slowly healing or non-unions is actually helpful. The problem is that most of the studies have significant confounding factors in that what has happened is that they've had revision fixation and the addition of bone morphogens. So it's difficult to identify which is the dominant factor. And our clinical experience is that by improving mechanical stability, the fracture will heal. So it would seem that in most cases, the addition of a bone morphogen isn't necessary for achieving union.
Amunye asks, is there any role for dynamization of the fracture anymore? I think the term dynamization it's an unfortunate word for what's being described. So the way I imagine it is that when you're dynamizing a fracture, what you're actually doing is dynamizing the construct. So you're dynamizing either the bone in relation to the nail, or if it's with an external fixator, you're destabilizing the external fixator in some way. So there were methods for both of those techniques in which you dynamize the fracture. What the end result was intended to be within the fracture plane was to allow the fracture ends to come closer together or to touch, and for there to be load transference across the fracture site, which had the increase of stabilizing the fracture site and reducing the strain. So although the term was dynamization for the construct, the intention, as I always understood it, was to increase the stability at the fracture site and therefore decrease the strain. So do I think there's any role for it now? I personally don't do it very often in isolation, but if I think that there has been a nailing and the fracture ends are being held apart, and it will help if they're brought closer together, then I will dynamize, but I would often use interfragmental screws as well, because I'm trying to address the strain environment within the fracture site.
No, I think that there is no evidence in intramedullary nails to suggest that dynamization either takes place or works. I think that, as Bob said, if there is distraction, then clearly that's going to slow fracture union down. So closing that by allowing the fracture to oppose better, I think, is good. And James Richardson, I think, looked at or published on this and identified two strategies. One, what he described as type 1 dynamization, where there's progressive closure of a fracture gap, which I think is reasonable. This is with external fixation. And then type 2, where loading produces cyclical micromotion, what he termed type 2 dynamization. And I'm not sure there's any evidence that that happens with nails. And I think there's probably very little evidence to suggest in most fractures with most external fixators that happens in that situation as well. So I think if there's a gap, yes, it's important to close that, but no, I don't think routine dynamization, if there isn't a gap, is helpful in achieving union.
We've time for one last question, and Alexandru from Romania asks, do you use the masculate technique? I would suggest that in terms of bone union, the masculate technique is not quite what we've really been addressing today. So the masculate technique, for my part, is predominantly to deal with a bony defect, and it's an alternative to bone transport. So yes, I think if there is a bony defect at the time of the initial fracture management, you may choose to address that with a masculate technique, and I periodically do. But as a later procedure, if I hadn't planned it from the outset, no, that's not what I would be attempting to do at that point. So I may use it as part of a primary plan for dealing with a bony defect, but not as a way of addressing a non-union at a later date. How would that be similar to your approach, Mark?
Yeah, we tend to favour bone transport largely because it's what I'm familiar with. I think the advantage of bone transport is it's much more predictable in terms of outcome. And I think what you end up with eventually is normal remodeled bone, where the evidence in masculate would suggest that the bone is never normal. And there was quite a nice study published by Ian Pallister from Swansea, reviewed reasonably large series of about 18 cases where, and about half of those had a satisfactory outcome, but in the other half, the outcome was unsatisfactory. So I think the lack of predictability would lead me down to do transport rather than mascale in most cases.
So I'd like to thank you all very much for the questions that you've sent in. We will have a further 10 minutes or so online afterwards, where Mark and I will address as many of the other questions as we can by text. But thank you once again for letting me talk to you this afternoon. And over to Mark to sum up.
Okay, thanks, Bob. Yeah, we'll be here for a little while answering some of those questions. So I'm just going to leave you with two slides, the take-home messages. So what I want you to take home is the fundamental importance of preserving vascularity around the fracture and reducing the amount of soft tissue stripping, an understanding of the biomechanical principles of how fractures heal and how we can influence that with implants, both initially and then during the fracture process, and apply that via the unified theory of fracture repair, and look at managing our delayed and non-use by mechanical means rather than autologous bone grafting. So I'll just leave you with the last slide, which you've seen before, is to look at this and think, when I've trying to encourage union, what I want to do is to shift this curve to the left, to assume the pattern that a normal fracture would undertake. So to reduce the interfragmentary motion of the fracture by my intervention. So not looking to influence biology, but looking by simple means to influence the mechanics and the mechanical environment of that fracture. Thanks very much for listening. Bob and I will try and answer quite a number of your questions. But also, could I remind you to go online and to click this link, which will allow you to assess this. And this webinar will also be available in about 2 days' time to see on the AO website, which will then be available, hopefully, in perpetuity. Thank you very much for listening, and goodbye from Zurich.